Welcome to the next section of the Critical Care Survival Guide. This section, Vent 102, will focus on how to choose ventilator settings for your patient. You may be asking yourself, can you please just give me some standard ventilator settings that'll work for my patient every time? Unfortunately, I can't do that for you because there's no one-size-fits-all in the ICU, so no best mode that's going to work for every patient. But I'll help you out. Let's start with let's have a place to start. The first thing you're going to be asked about when you're setting ventilator settings is your tidal volume. Respiratory therapists will say, hey doc, what kind of tidal volume do you want? And you say, don't just pick a number and use it every time. We actually like to start with something in the 6 to 8 mLs per kilogram ballpark. Remember, that's not the patient's actual body weight. That's going to be using predicted body weight. Next, you'll want to look at your respiratory rate. So normal average is somewhere in the 12 to 16 ballpark, but again, depends on your patient and depends on what tidal volume you set to begin with. But together, these typically look at a 6 to 8 liter per minute ventilation. Your patient may require more than that, but that's what's considered a standard place to start. The next thing that you'll set is your PEEP. If your patient's significantly hypoxic, 5 might not be enough, but 5 is our usual starting place for PEEP. And then finally, you'll need to set your FiO2, and this is titrated either based on your O2 sats or on your ABGs. We typically lean towards just going based on the pulse ox monitor and targeting an oxygen saturation of 92 and better. Although if you're getting frequent ABGs, you could use that as well. So now that you have some ideas of where we start, let's talk about a few specific circumstances in the ICU that you may run into that you would need to adjust these settings. The first one is ARDS. We have a whole lecture on ARDS, but I want to remind you that the low tidal volume ventilation that we use in ARDS is associated with decreased mortality, so it's really important to implement in these patients. That means starting with a tidal volume of around 6 mLs per kilo, predicted body weight, and then checking a plateau pressure. We're targeting a plateau pressure less than 30. So when you check your pressure, if it's above 30, you'll slowly work down on the tidal volume until you can get a plateau pressure under 30. And so you may end up with a tidal volume in the 4 to 6 range, which is the standard of care for ARDS. Remember that when you drop down those tidal volumes, you may actually have to increase your respiratory rate because you're decreasing the patient's minimum ventilation. The next circumstance we'll talk about is airway obstruction. So you think about this in patients coming in with acute COPD or asthma exacerbations. These patients are very tight and they're going to take a long time to expire. So the way you compensate for that on the ventilator is by giving them an increased I to E ratio. So instead of 1 to 2, we may use 1 to 3 or 1 to 4, or you can shorten your I time, again affecting that ratio. This gives them long enough to expire and not air trap, which can cause auto PEEP. If you see that happening on the ventilator, what you want to do is turn up your tidal volume and actually decrease your respiratory rate. So even though they're taking a bigger breath, they could potentially have more time to exhale. You may need additional sedation for these patients as well. Next, we'll talk about a couple of hyperventilatory states. The first one of these is metabolic acidosis. So think about these patients, if they weren't actually on a ventilator, they would be very tachypnic, sometimes up into the 30s, trying to compensate to keep a normal pH. Once you intubate and sedate them, you have to do this for them. So whether you accomplish that by higher tidal volumes or higher respiratory rates is up to you. Frequently, they need both, though, to maintain their pH. The other hyperventilatory state that's important to know about is acute CNS catastrophes. So if you have a large stroke, these patients frequently have elevated intracranial pressures, and you'll want to target a slightly lower PCO2 in the 30 to 35 range to help decrease those intracranial pressures ever so slightly with the ventilator. Again, that's accomplished by setting higher respiratory rates typically, or tidal volume, and then checking your ABGs. Next, hypoxic respiratory failure. So this can be lots of different things. You think of pneumonia, CHF, pulmonary edema, ARDS, and you're going to deal with each of them a little bit differently, but in general, we tend to use increased PEEP in these circumstances, especially when the process is more homogeneous throughout the lungs. It's going to work better with a higher PEEP. You have to keep in mind, though, when you turn the PEEP up, you're decreasing preload and afterload. So very sensitive preload patients, such as a patient in shock, are not going to appreciate an increased PEEP, and I typically try to get them resuscitated as much as possible before I start turning up their PEEP so that I don't worsen their hypotension. It's also important, again, to realize that you decrease afterload as well, so slightly higher PEEPs, 8 to 10 range, can be very helpful in patients with congestive heart failure in exacerbation because you'll offload the heart with a slightly higher PEEP. So all of that combined, you're going to use your basic settings to begin with, and then some of these specific hints to try to make an educated guess about what the appropriate settings are, but I don't expect you to get it right every time. So check at ABG after 30 minutes, and then make further adjustments from there. Hope this has been helpful, and thanks for watching this episode of the Critical Care Survival Guide. See you next time.